the interest I had with bisphosphonates is bisphosphonate being, is it potentially a cause for atrial fibrillation? And I don't know. And if you read the review, what it suggests is that it suggests there's several ways bisphosphonate can work and how it can potentially cause arrhythmias, but they are all not exclusive to bisphosphonate. They're exclusive to aging, they're exclusive to a lot of other factors. So the the reason I wrote the review was to highlight that there's still gaps in our knowledge, and fundamentally understanding the mechanism or the impact bisphosphonate has on the heart will help us draw out some information whether or not there is a preponderance for bisphosphonate to cause atrial fibrillation, or really there isn't anything to worry. Yes, they may cause some changes, but they're not significant enough to cause an arrhythmic event. But I would, it'd be
Awesome.
interesting if clinicians at the back of their head keep AF as a potential, you know, uh, adverse outcome that may or may not occur. So just sort of trying to have a bit more vigilance from that perspective, because we don't know. I mean, in an ideal world, we would like to prospectively monitor patients. So you put a patient on bisphosphonate, you prospectively monitor them over several years, and then you see whether there's a higher preponderance of AF development in patients who have been on long-term bisphosphonate therapy versus patients who have not been on bisphosphonate therapy. So, trying to sort of draw whether that kind of strong evidence can actually be undertaken or not, that could be one thing, sort of increasing vigilance. Obviously, the other thing is that increasingly bisphosphonates are just as it's a class of drug. More and more times the drugs are evolving. So, removing certain molecular attachments in these drugs can also make it less risk. So perhaps, you know, keeping up to date with the newer evidence with regards to what types of bisphosphonates are being released and how safe are they, then that would probably be an important aspect as well when trying to keep these ideas in mind with regards to whether or not bisphosphonates are high risk or low risk with regards to development of AF. Also note
Mhm.
that it's not a straightforward answer, because if you look at it from an osteoporosis, let's look at it from an osteoporosis perspective. Most of your patients who have osteoporosis are going to be older females. Okay. And and that's a risk factor. So you're going to have a risk factor where it's older generation. You're going to have, it could be females who have osteoporosis, and let's say they prescribe them bisphosphonate. Then you look at the risk factors for AF. The risk factors for AF are also old, patients of increasing age, and you can also have females who are also predisposed to AF. So now you don't know what causes which. So it could be that a patient may be on bisphosphonate and also develop AF, but the development of the AF could actually be because the patient already has all the risk factors for AF, which is aged, hypertension, um, a female perhaps over 70 years old. They could already carry existing risk factors with them, and it's not really the bisphosphonate that's causing the AF, but it probably is their risk factors that they already have that makes them have AF. So it's important to just appreciate that there is that potential that AFib can occur, and that maybe sort of, I wouldn't say changing in protocol, but what I would call slightly extra vigilance in patient monitoring would be useful. So trying to understand that if you have a patient that has a high risk for AF, then and you're giving bisphosphonates, it's not contraindicated potentially. So do you then say, you know what, I would like to just review this and have a more sort of close monitoring of the individual, like frequent ECGs, just to check whether everything's fine, to report straight away back that the patient, if the patient has palpitation, and if indeed the patient does develop palpitation, to have it in the back of their mind that is it bisphosphonate that's causing the AF or not. So it's not a straightforward answer because the evidence isn't there at the moment yet. It's not a straightforward answer. Oh, I've put you on bisphosphonate, you've got AF, I'm going to stop bisphosphonate. And that is wrong, because there's no evidence to suggest that you must straight away stop bisphosphonate. What the evidence may suggest is for you to rule out other conditions and then see whether bisphosphonate is one of the reasons. So it's not just a straightforward, let's blame bisphosphonate or let's stop bisphosphonate therapy. It's really trying to manage what is important for the patient, identifying what's the risk, what's going to kill the patient first. Is it the AF that's going to kill the patient immediately, or is it the reason for giving bisphosphonate? So it's all about risk management. So a lot of my work is trying to understand the basic principles, how the channels in the heart function, how the excitation of the heart occurs, how we can prevent arrhythmias, how do drugs control certain channels. Because what's important about antiarrhythmic drugs is that some drugs can prevent an arrhythmia from occurring in the atria, but they may actually potentially cause arrhythmias in the ventricles. And there are drugs that can cause arrhythmias in the ventricles that potentially can cause arrhythmias that that are protective for the ventricles, but can potentially cause arrhythmias in the atria. So trying to understand that complex interaction and devise strategies that could best understand how arrhythmias occur, then we can actually treat them. I don't solely do osteoporosis. I do a lot of what we call electrophysiology research. So my work is really focusing on the electrical property of the heart, and I'm trying to understand what are the factors that the mechanisms for the development of arrhythmias. So you could have many mechanisms that cause arrhythmias and many risk factors, whether it's a drug induced or whether it's a genetic induced development for arrhythmia. So whether it's a lifestyle or whether it could be a disease, that means diabetes induced arrhythmia, various things. So my focus is, I don't focus on a particular disease, but I focus on trying to understand how various different diseases or various different drugs actually alter um, the mechanisms that can perpetuate arrhythmic events in humans and in animals.